Thank you, sir. Good evening, everybody. Welcome you all. The 30th webinar of BSRI. BSRI regularly organize this type of webinar for the development of the society and for the neuro or different fields for the radiology outfield. And welcome, especially I welcome the two speakers. One speaker from University of Texas, Dr. Riascos. He is the Chief of Neuroradiology. He is the Vice Chairman and Director of Center for Advanced Imaging Process in the University of Texas. He has a lot of experience, he has a vast of experience. I hope their presentation will help all the young radiologists, especially those who are interested in the neuroradiology. And the second speaker, Dr. Indani Noy, a very interesting topic about the evaluation of the orbital tumor. And it is a very challenging for the radiologist to diagnose the orbital tumor. I hope the two presenters will give you a lot of information and it will be helpful for the radiologist. And we have, I welcome the panelists, especially Professor Dr. Mohammad Botul Alam Mondol, sir, for coming this webinar. I hope he will give his lot of experience about neuroradiology, and especially he is very much interested about the neuroradiology. He always supported us, and he is also I think he is also the mentor of Neuroradiology Society of Bangladesh. And he organized neuroradiology workshop in his center, and he has a keen interest to develop the radiology field, especially with the collaboration with the neuroradiology. I hope his experience with this webinar will helpful for the neuroradiologists. And thanks everybody to welcome you all for this webinar. I again welcome you all to this webinar. Thank you all.
Thank you, sir, for your excellent welcome address. So at this time, I think it's time to move on to our speakers, because Shakil sir has already introduced our speakers and given their credentials. So I'll not take that time anymore. So it's my pleasure to now welcome to the presentation Dr. Roy Riascos, who will be speaking about imaging of imaging of CNS infections, particularly focusing on immunosuppressed patients. So Dr. Roy Riascos, we are proud to have you here. Please proceed.
Hello, good morning. I want to first thank you, the BSRI, for this kind invitation, and RAD-AID for as always participating in getting the world closer. So let's start. When I was invited to speak about infections, of course I could cover this for hours, but for half an hour, I think that one of the most important topics that we can cover and make it short is how do you face an immunosuppressed patient that is very different than just facing an immunocompetent patient. We learned when we're training a lot about how to look for regular type of infections, but there's a new challenging group of patients that, because of HIV, because of transplants, because of other forms of immunosuppression, they just have a very different reaction, and they get infected in a slightly different way. So the objectives of today are going to be to review those frequent infections that happen in immunosuppressed patients, differentiate the viral from the parasitic infections using MRI, and review the imaging features of cryptococcal meningitis, which is one of those infections that we were going to review. So I don't know why we have these blue bands in the middle, but I'll see if I can take them away.
I'm clearing up.
So okay, good. So this first case that we're going to see, and I'm going to show you first some cases, and if you already know what they are, maybe you don't really need to stay the whole 27 minutes. But if you see that something is still challenging for you, maybe I can give you a little bit more information so next time that you get something like this, you can really understand how to face this. So this is the first case. This is a male patient who's 50 years old, and he came to the ER, and we did the CT of the head. And you see in the CT without contrast how there's hypodensities that are seen symmetrically, and they're kind of diffuse on both hemispheres. If you remember seeing patients that are 50 years old or 40 something years old, the volume for this patient is really reduced. So this is a patient that does have some atrophy of the brain. So we did an MRI of the brain. You can see the T2 weighted images on your right, and you see there's increased T2 signal noted diffusely on both hemispheres. It's central. It is involving the hemispheres symmetrically, and it also involves symmetrically the anterior and posterior aspects of the brain. These findings can be seen on the FLAIR sequences, and see that they can also involve the brainstem and the cerebellar hemispheres. They're very central and diffuse. And what is really interesting is that having this diffuse disease, there is no enhancement. This is the T1 postgadolinium that you have on your bottom right corner. The second case is a patient that is 52 years old, and we have the CT shows some patchy, irregular regions of hypodensity that involve the subcortical white matter. When we do the T2 weighted images, you see that there are actually lesions that are present, that are on both hemispheres, and that some of that white matter changes correspond likely to vasogenic edema. Some lesions go, or the edema extends all the way to the hypothalamus, and some to the left cerebellar peduncle. And after putting gadolinium, you see there's some very interesting enhancement pattern where you have kind of eccentric rings and not just a regular ring of enhancement. This next case is a 47-year-old, and you see a very similar lesions as we saw in the previous one, patchy lesions on both sides. I apologize for the low quality of how the diffusion is presented. The ADC map shows you there's no restricted diffusion in any of these two lesions, but the huge difference is that there is not a lot of mass effect in these lesions. They still involve the subcortical white matter, and there is no enhancement. This is a fourth case, a 36-year-old patient that comes, and here's the FLAIR sequence. You see a hyperintensity involving the right frontal lobe, crossing a little bit the corpus callosum, and you see the septum pellucidum also being involved. On the T2 weighted images, you start seeing some irregular rings of hypointensity. And after contrast, you see nodular enhancement. You see also enhancement on the left side. I'm sorry, I'm getting a lot of feedback from a microphone. And this is the final case before we start. And this is a patient that is 36 years old, and the T2 shows a large amount of hyperintensities in the basal ganglia. The FLAIR also demonstrates them, but not only that, if you look carefully, the FLAIR signal is also delineating the borders of the midbrain in a way that it usually doesn't. So there's leptomeningeal involvement around them. After putting contrast, they didn't bring it, but these lesions would not enhance. So these are 5 typical diseases that can happen in immunosuppressed patients. So let's kind of review how we're going to image the patients that are HIV or immunosuppressed, and how we can get to a closer diagnosis to guide our clinicians on what to do with these patients. So typically we do a normal imaging protocol for our HIV patients. We do a T1 and a T2 and a flare, and of course we add contrast, and you need to add some sort of susceptibility image. You can do a gradient echo image or a susceptibility SWI image. In the AIDS dementia complex, which is a neurodegenerative case, up to 50 to 20% of patients with AIDS will have some sort of neuroimaging findings. Demyelination and gliosis of the white matter periventricular T2 hyperintensities is typically seen. They have no mass effect or enhancement and spares the subcortical white matter. So when we see the AIDS dementia complex, which is how the virus actually affects the brain, and it's very frequent to see it. As you can see it almost in a fifth of the patients with AIDS. This is mostly a demyelinating disease. It's going to be symmetric. It's going to be involving the anterior and posterior regions of the brain. It's going to spare typically the subcortical white matter. So this looks a lot like when we're seeing a toxic involvement of the brain by methotrexate, say, or radiation. When you do a CT, this complex is going to see like confluent periventricular areas of hypoattenuation, so low attenuation. You're going to have volume loss. The virus does volume loss. It's a little bit more predominant towards the frontal lobe, and the general of the corpus callosum can be involved. This is one of the diseases that can involve the corpus callosum. If we do spectroscopy, it will have a decrease in NAA and an increase in choline. And as you know, with demyelinating processes, myonocytol peaks can be high. So some of the pros when we're identifying HIV encephalopathy complex is that if you see mass effect or enhancement, you're not seeing, this is not actually the HIV encephalopathy complex. So for the most part, viruses do not enhance. This is a case of HIV encephalopathy. You see that the disease is symmetric. It aspects of the brain, and it spares the subcortical U fibers. Look at the subcortical U fibers. They are spared. Can everybody hear me?
Yes, we can hear you.
Okay, I'm sorry. Something said here I was muted. Okay. So you see that there is no enhancement. So this is a great key. If you have brain disease in an immunosuppressed patient and there is no enhancement, you immediately think about viral processes. If there's enhancement, then you think about other things. You see that there's no restricted diffusion whatsoever in the DWR and the BAC maps. This is another case where you see the same thing. A lot of brain atrophy and symmetric, very well central, very homogeneous disease that affects the periventricular regions, sparing the subcortical white matter. So anytime that you have an immunosuppressed patient that comes like this, and you have to always suspect that this is, if it's an HIV patient, that this is an HIV-related encephalopathy. Let's go to the second virus that affects immunosuppressed patients, which is the progressive multifocal leukoencephalopathy, which is part of the polyoma JC virus complexes. It's often fatal. It's an opportunistic infection of the CNS. The way it presents is very different than the HIV. This one is patchy, asymmetric. It loves to involve the subcortical white matter. It can be monofocal, but it can also affect the gray matter, but it typically is in the white matter. People carry 50 to 90% of the world population carry this virus, but it only will manifest itself if the patient is immunosuppressed. The initial infection can be completely asymptomatic, but when it starts reacting, the CD4 cell counts usually are below 100 cells per millimeter square. And this low CD count will flare up the disease. In imaging, it's one thing that is very important is the involvement of the subcortical white fibers. So look at this case. We have patchy hypodensities on CT involving the subcortical white matter. You see that they're in multiple regions of the brain, including the basal ganglia. There is not a lot of mass effect. That is not always the key, because in acute PML, you can have some mass effect. And one of the things that is very important is that when you add gadolinium, there is no enhancement. So every time that you see no enhancement, you think viruses. And the virus that you're going to see in this case is very different pattern than the one that we saw in HIV encephalopathy. This would be the progressive multifocal leukoencephalopathy. Sometimes you can have cytotoxic edema because of this virus, and you can have some restricted diffusion. So every time you have viral loads and viral diseases, the viruses reproduce inside of the cells, and because they reproduce inside of the cells, they compete for the ATP. That creates a little bit of vasogenic edema. So in viral encephalopathies, in the early stages, you could see some vasogenic edema that can be represented as restricted diffusion. It is not frequent, but you can see minor enhancement in some of the edges. So when I told you it's no enhancement is virus, little pieces of blushes of enhancement really don't count. You're going to see how the other diseases that affect the central nervous system really have a lot of enhancement. Now, this is a case I brought to you. So because in a lot of the books, they say that PML usually has volume loss. In the top, you can see the patient in an acute phase. The PML can actually give you almost mass-like lesions. So in very acute ill patients with PML, it can be mass-like. So don't put that as don't exclude PML if you see mass-like lesions. And of course, after treatment, they become smaller, and they have the typical pattern that we have been explaining of patchy subcortical. And these are the little blushes of enhancement I'm telling you. You'll see that they're very different than some of the other diseases that affect the brain. I brought this other one because PML is another of those diseases that can cross the corpus callosum, and you can put inside of your differential diagnosis. And also to remind you that they can restrict diffusion if they are in the acute phase because of the acute cytotoxic edema they can produce. So after some of the new treatments that we have with HIV, like HAART therapy, we have seen a new way of manifestation of PML, which is what we call the IRIS, which is the immune reconstitution syndrome. So in patients that have recovered due to HAART therapy, what happens is that now the body can have an immune response to this virus. And the results in imaging is that now you can have patchy enhancement and mass effect. Patients that have the IRIS complex tend to have better survival than the ones that don't. So this is a PML patient that was under HAART, and look at the pattern of enhancement. It's always like these little dots. It's very little vascular enhancement that happen mostly in the mid part of the lesion. So once you've seen a couple of these IRIS cases, you'll see it's not homogeneous enhancement. These little dots happen. So one thing that is very important is to know if you have an immunosuppressed patient, an HIV patient, is have they had any HAART in the therapy with them? Or if you're seeing an immunosuppression of a patient that has MS and that they're taking immunosuppressors, you need to know what the therapies are like, because it has also been described in some patients that have immunomodulators as therapy for MS. PML can happen in odd places. This is a patient that had a PML that was not subcortical. Look, this patient had a kind of a central PML in the midbrain, in the basal ganglia, still no enhancement. We knew it was viral, but it was affecting the mid portions of the brain. So not all of the PMLs are peripheral and subcortical, but the typical thing is that the viruses tend not to enhance. In spectroscopy, here you have the spectrum of these patients in the middle of a lesion. They can have decreased NAA, increased choline. I didn't have a short TE, but they tend to have increased myoinositol. So let's continue with toxoplasmosis. Toxo is the most common mass lesion in 8 patients. This is the most common mass that you're going to see. You're going to see multiple ring enhancing lesions. They're going to typically prefer the corticomedullary junction and the basal ganglia. They enhance. If you see an enhancement that is an eccentric target sign, this is something that can really guide you to think this is toxoplasmosis. They do not extend into the ependymal surface. And this is a nice way to differentiate them from lymphoma, because lymphoma is so similar to, even though lymphoma is not an infection, it manifests itself in a very similar way as toxoplasmosis. Acute infections can have vasogenic edema and toxoplasmosis, and they rarely are going to have hemorrhage like a primary lymphoma can. So toxoplasma is the most common opportunistic CNS infections in AIDS patients. It can happen in up to 50% of them. It is extremely difficult to tell in imaging the difference between toxo and lymphoma. So what we used to do is empirically, the treatment was usually administered to see if it was toxo, and then if it didn't get better, we thought it was lymphoma. Now we have other ways of doing it. Through imaging, you can even do SPECT or PET using thallium-201 in the brain. Both would be positive for lymphoma, or you can also use spectroscopy. So look at this case. It looks very patchy, look very subcortical. It looks very similar to some of the PML cases I was showing, right? But when you start seeing carefully, you actually see that they're central lesions. And when you add contrast, very different to the PML, now you have enhancement. And see that this enhancement looks like an eccentric ring, another eccentric ring, and another eccentric ring. This is called the eccentric target sign. These are very, very particular of toxoplasmosis versus some of the other diseases that we can see. They don't always present with eccentric target signs. Like toxoplasmosis can be diffuse and can be seen as nodular. And then if your imagination helps you with me, you could think this could be an eccentric target sign, but not all of them manifest themselves. One of the most important things is that these lesions will enhance. They will enhance. The differential always when you have a toxoplasmosis is you have to differentiate it with primary CNS lymphoma that happens in patients with immunosuppressed. So this one, as with toxo, will involve the basal ganglia. Lymphoma doesn't go as often to the subcortical white matter, but it can. Lymphoma and toxoplasmosis both can affect the corpus callosum, and they can extend into the subependymal surface, which makes the difference between. This is an easy way to differentiate lymphoma from toxo, is if you see periventricular enhancement because there's subependymal involvement. That never happens with toxo, it happens with lymphoma. You can have vasogenic edema and lymphoma. Lymphoma is less frequently to have extensive vasogenic edema. You have a little bit of edema around the surface. And the enhancement of lymphoma tends to be very homogeneous when the patient is immunocompetent. In immunosuppressed patients, the enhancement of lymphoma can be ring-like. And that's why it makes it so hard to differentiate it from toxo. You can see it there, and it can have hemorrhage in immunosuppressed patients. So this is a case that looks very similar to toxo, as you can see. Central basal ganglia and peripheral. You have vasogenic edema, not as much. It does have regions that are very hypercellular. Remember that lymphoma is small blue cells in pathology, so they tend to be hypercellular. So you get a little bit of restricted diffusion. And look at the enhancement. This is not an eccentric ring sign, but it can be very close. So always have that in your differential diagnosis. And this is the last one we have. I only have like 5 minutes to wrap up. So we're going to finish with cryptococcal meningoencephalitis. So this is the third most common cause of infections in HIV patients. Remember that the first one was HIV encephalopathy per se, and toxoplasma was the second. We always also said that toxoplasma was the first that gave you mass effect. but this is the third most common cause of infection in AIDS. It has a high propensity for the leptomeninges, and it's going to look as hyperintense on flare. You can have meningeal enhancement, but you can also not have it. And the reason for this is that what happens with Cryptococcus is that it gives you an exudate. And this exudate that the Cryptococcus gives doesn't always trigger an immune response, especially in a patient that is immunosuppressed. So even though you have a meningitis, you will not have the enhancement that you're used to seeing in some of the meningitis. But the best way to detect it is to do a flare, because you will see all the leptomeninges being hyperintense on the flare. So I think the flare is key when you're doing this. And of course, there's some very particular findings here, which is that gelatinous substance can creep through the ascending perforators of the basal ganglia through the thalabocystinoid arteries, and give you little cysts that are non-enhancing in the basal ganglia, which we call gelatinous pseudocysts, which are very typical of this disease. They can go into the parenchyma and now start enhancing and have kind of a mass lesion, and then we'll call it cryptococcomas. But typically, we won't get to cryptococcomas, and if you have them, they will ring enhance. So this is what I was telling you about. The mucous gelatinous material is going to be high in flare. It won't saturate like the CSF, and it's going to be good because it involves so much of the leptomeninges. It can have hydrocephalus, especially if it affects the corpus callosum. So this is the last slide that I have of literature. The lesions can be high on diffusion due to the very high viscosity of the gelatinous material, not because of high cellularity. If you always look for these small cystic lesions in the basal ganglia, and it can really guide you through Cryptococcus. And the infection causes very little inflammatory response. So this is a typical patient with crypto. You see the basal ganglia is full of these very little cysts. These are gelatinous pseudocysts, right? And when you do the flare, they still can be seen as high intensity. There's very little flare changes in the periphery in this patient. And most importantly, they do not enhance. So crypto does not typically enhance because it doesn't create an immunoresponse. This is another patient that had unilateral pseudocysts on one side. And when we do the MRI, you can see that the basal ganglia is involved asymmetrically. It doesn't have to be symmetric. In this case, it's really not restricted diffusion. And one of them is starting to become a nodule and starting to enhance. This is going to start becoming a cryptococcoma. So in conclusion, I created this chart. This is part of one of our publications in the Journal of MR Imaging that really tells you if something is symmetric, subcortical, basal ganglia, it enhances meningeal enhancement, subependymal disease or bleeds. You can really go through the chart and favor one over the other. I think it's very important to remember that viruses tend not to enhance. And if they enhance, they enhance very punctate, in a very punctate way, and especially in the patients that have PML iris. The two that really enhance are going to be toxo, and I always include lymphoma because they're so similar. If you see subependymal spread and bleed, they tend to happen more in lymphoma than in toxoplasmosis, and these are just key if you're doing regular MRIs and you're not doing anything advanced for them. The only one that is symmetric and central is going to be the HIV encephalopathy. So this is kind of an algorithm to see how to conclude everything we've said. You have a flare lesion. If it's symmetric and periventricular and no enhancement, you know it's HIV encephalopathy. If you have a subcortical white matter lesion in the flare and doesn't enhance, you have to think about PML. If it enhances, then you see it's patchy with no mass effect and the patient had heart treatment, then it's PML iris. Now, if it enhances and you see mass effect, it can be toxo or lymphoma. So always look for the eccentric target sign, which will guide you towards lymphoma. Or if you see subependymal spread, I'm sorry, eccentric target sign towards toxo. If you see the subependymal spread, it'll guide you towards lymphoma. And now, if the flare lesion is mostly on the south side, and with basal ganglia cysts, you think about Cryptococcus. So let's review the cases that we saw. The first one, which had these subcortical lesions and had eccentric target signs, was toxoplasmosis. The second one that was very diffuse and central and symmetric was an HIV encephalopathy. This one that had eccentric regions that were not enhancing on both hemispheres involving the subcortical U fibers was PML. This one that had a bunch of lesions that were in the basal ganglia that were enhancing a lot was a toxoplasma case. And finally, this one that had pseudocysts with flare surrounding the midbrain was Cryptococcus, and I told you it was not enhancing. All right, with this I end. This is in Spanish my way to say thank you, which is gracias. And I'm really honored to have been part of this, and I'll wait for your questions later.